Alrighty, Bismillahirrahmanirrahim. Today we are going to start with the second part of the lecture of the abdominal examination. Abdominal examination, as you know, now it has three parts. First is the examination of the abdomen proper. Second is the examination of the hernial orifices, and the third part is all about examination of the genitalia and the per rectal examination. Though we believe still that is a small portion of the examination. So let's start with the examination, and you can see this is the second part of our lectures on examination of abdomen. You must understand that we already completed the first part. Now we move on to the second. This lecture can be taken as examination of the hernia alone itself, and then we relate this with the examination of the abdomen. So you can interrelate them, or you can see this lecture as an alone entity, and you get an examination of command examination of the hernia. So this is the lecture that you need to completely go through, and then you'll be able to follow all the steps. We already have discussed that examination of the abdomen has 5 steps. Abdomen proper. It includes inspection. It includes superficial and deep palpation. Then palpation for organomegaly, percussions, and auscultation. When we move on to the examination of the inguinal hernia, so this again we need to understand that this examination of hernia would comprise of 3 components. Whenever you get an examination, you can get an order of a command that examination of inguinal hernia. Immediately in your mind, you need to understand that going to see 3 things. So those 3 things include inspection, palpation, and auscultation. Though percussion is important at some point, but it is not as important in examination of a hernia. When you have a hernia, if you have an inguinal swelling, you may have to percuss that swelling in detail. Let's start formally. Examination of hernia. First of all, we also understand what is a hernia. What word by word you need to understand the definition. It is an abnormal protrusion of a viscous or a part of viscous through a potential weak space of its containing cavity. So hernia is not protrusion of tongue. So it is protrusion of a viscous or a part of a viscous through a potential weak space in your face. But this is not hernia. So hernia has to be an abnormal protrusion of a viscous or a part of viscous through a potential space of its containing cavity, which means it would include the ungual herniations, diaphragmatic hernias under diaphragmatic hernias, pelvic floor hernias, and all these things. And most important thing are the hernias of the ventral, lumbar, and the inguinal family, where we can have hernias anywhere, everywhere on the abdomen. We're talking about the abdomen, and whenever you get a command, the examination of a hernia, so it can be lots of areas: ventral hernias, lumbar hernias, inguinal femoral hernias, and you need or rarer hernias like the Spigelian hernias or incisional hernias, which can be anywhere you can see. So what you can do is you broadly describe them into ventral hernias, which would be epigastric hernia, paraumbilical hernia, a true umbilical hernia, then inguinal region hernia, inguinal hernias, including femoral hernias, maybe internally an obturator hernia, a lumbar hernia, and then lots and lots of incisional hernias, and then the varieties. And we are going to examine all of these while we are inspecting the abdomen. Now, very important. If you are examining this hernia patient as a primarily an examination of inguinal region, and you're starting with the examination, so this patient can and should be examined while the patient is in standing position, which means that you're not going to ask the patient to sit down, and examination would start while the patient is standing. Whereas there is a second pathway in which you have completed the first part of the examination, you have completed the abdomen proper, you have done the inspection, deep superficial inspection, superficial palpation, deep palpation, organomegaly, auscultation, and percussion. Now that patient is lying on flat on the bed, and now you just need to ask the patient to take off his pants or the sheet that you're covering, so that you'll be able to examine the one's abdomen for any hernias, and then the perineum or the inguinal region. So we will discuss this thing. So let's suppose that the patient or the command is the examination of the inguinal region, and the patient, we start examination by asking the patient to stand up. Very important slide, and we all need to understand. You are going to expose the genital areas of a male or a female, and you definitely mean a chaperone or someone to assist you while examination. And remember, male or a female, you always gets confused, but it is preferable that you bring someone of the gender of the patient. So if you're female, you again ask for a male chaperone so that you examine and the patient is comfortable. If you're a male, so and the patient is female, it's all good, it's nice, it's mandatory to have a female chaperone available. Okay, then you need to sit and squat in front of the patient while the patient stands. Ask the patient to have broader feet, expose the area, and ask him to look into the sky. Turns the patient's head towards the wall. I would show you what do I mean by this. And so it gives you a sense of privacy. While he or she can hold their pajamas or a chaperone can do this, ask them to cuff. This is the inspection. This is how you start. Inspect from the front and inspect from the back as from back side as well. Okay. So while we examine this area, so in this you can see have two types of positions you can examine. So the patient is standing and you're sitting in front. Either squat or take a small stool and sit in front of the patient. You need to inspect from the front and from the back on both the lumbar areas, anterior abdominal wall with a broad toe. Ask the patient to cough and see for any bulges in all these areas from the front and from the center. The other thing that I mentioned is you always keep the patient standing. While if you see the examiner should stand beside the wall, and you need to turn the patient in this direction so that he does not feel uncomfortable to just expose himself and standing or herself and standing, pointing to an open room. So this is a very important thing that you need to do, gain the confidence so that patient knows there is only one or two people who are examining and not the whole room. When once you inspect, what do you need to inspect? You need to see if there is a swelling or not. If there is a swelling, you mark that swelling and see for any change when the patient comes. But if there is no swelling, so again still ask the patient to cough and see whether there is a swelling gets visible. So you ask them to cough. Khansi kare. Don't keep on asking them to khansi kare. If there is a swelling, you need to see the lecture on the swelling, right? And it has 5S. So you need to determine the site, the size, the shape, the surface around structures, and then the margins, reducibility, pulsatility, contents, and transillumination is very important for inguinal hernias. The second important thing is when you need to ask to cuff the patient, you need to don't push the patient too hard, but it needs to be a couple of cuffs. And if you see the whole swelling comes into the scrotum while the patient is standing. Ask two questions. Is there is a pain? क्या इस सूजन में दर्द होती है? क्या इस गिल्टी में आपको दर्द होती है? And wait for the patient's answer. Do not hurry on to palpate in palpation or to touch that area. बहुत दर्द होती है. So ask them to touch, ask them to press themselves to let you know how much is the pain. And they just would press and say, बहुत दर्द होती है, थोड़ी सी दर्द होती है, अगर ज़्यादा दबाएं तो दर्द होती है. This give you an idea how painful it is and how rash you can be with your examination. Otherwise, if it is tender, you say, okay, fine, I won't be pressing it too hard. And if I do harm you, if I do tease you, just let me know and I'll ask the examiner that it's too painful to be examined. The other thing that you need to see when a patient says that it is painful, you need to rule out it's whether it is obstructed, it is strangulating, or and it is an incarcerated hernia. So, and then the next question is important question is you have checked for tenderness, You have asked questions for temperature, for tenderness, and any other sort of structures. Now the patient asks the patient one other question: does it disappear while you lie down? So all the scrotal swellings would not disappear when the patient lies down. And this swelling may or may not, a hernial swelling may or may not disappear. So if it disappears, we label it as an irreducible hernia. I mean, it doesn't. It is an irreducible hernia. Now, in irreducible hernia, you can have incarcerated hernias, you can have obstructed hernias, you can have strangulated hernias. Any sign of pain in an irreducible hernia is a sign of obstruction and can lead to gangrene of the bowel or ischemia, and it becomes gangrenous. So we need to be very careful with this question. Ask the patient to lie down and see whether it disappears or not. If it disappears, it's good. If not, first ask the patient, can you just help it to go in? Because the swelling and the patient are in relationship. They are together for many, many years, and he knows better how to reduce that swelling. Do not try to push it into the swelling. Next is we need to ask the question: is it painful to touch? And then the temperature. So now you palpate with the back of hands, press the swelling slowly, gently, pushing onto the temperature, and keep on looking at the face of the patient to identify whether there is a pain or not, and then compare the swelling, the temperature of the swelling with the surrounding structures. Now palpate the, can you reach above the swelling? Next question, can you reach above the swelling? So I know that this is the tenderness, this is the size of the swelling, the extent of the swelling, and now I need to know whether I can reach above the swelling. If I can reach above the swelling, this means that this patient has testicular swelling. It cannot be an inguinal hernia, or there can be an associated hernia, but the primary swelling that I am looking at is not inguinal swelling. It is a scrotal swelling, and there is a separate discussion, separate differential diagnosis of patient presenting with scrotal swelling. It can be a hydrocele, it can be a hematoma, it can be a malignancy, it can be a varicocele, a bag of worms kind of a sensation, it can be post-trauma, fibrosis, operation, but it cannot be an inguinal. So if you are reaching above the swelling, it is not inguinal hernia. You focus your examination onto a scrotal swelling. And for scrotal swelling, again, remember the slide for inspection, palpation, percussion, and auscultation of a swelling. So we move from this area to that lecture. If you can, just as mentioned, so you need to see the site size, shape, surface, and surrounding structures. You need to see fluctuation, fixity, reducibility, pulsatility, margins, mobility, transillumination, compressions, and compressibility, and consistency, and also palpate it for presence of varicose veins. Okay, and the second question that I've mentioned, that you need to ask the patient to lie down. Once you see a swelling, you identify that you cannot reach above the swelling. Now you need to start with 5S, which include the site, the size, the shape, the surface of the swelling. It is red, it's hyperpigmented, it has a scar on it, it is pulsating, or the surrounding structures, whether there are other abscess formations there, other incisions there, a previous scar there, and you completed that. Once inspection is done, you complete the same with the palpation. And then while palpating, now you can palpate the consistency of the hernial sacs to identify whether this is a hard mass, is it a soft cystic swelling, or it is bowel or omentum. Then you need to compressibility for vascular structure. You can have a vascular, a venous structure here, venous swelling here, which can be confused with an inguinal hernia. It disappears while lying down. It just comes back when the patient rises up. There is a cough impulse as well, but then this patient, you see that it is compressible. You compress it, it would come back when as soon as there is a mild increase in pressure and is a existing swelling. The site is also in the femoral triangle. Now you need to be very clear about the margins. how long it is. Is it a complete hernia? It is an incomplete hernia. It is a bubonoceal. It is a funicular hernia, or there is something in the lying in the inguinal canal. And you also need to know what is the site of the testes and the normal development of the testicular scrotal skin. Mobility is important for to know whether this is incarcerated hernia or an obstructed hernia. A hard mass, a relatively hard mass, which is fixed, is a sign that the patient may be having um, an obstructed or strangulated hernia. Then you need to see for fluctuations, fixity, reducibility, and pulsatility. Probably fixity is not a very important reason. Now you have right inguinal hernia. Remember, you need to do the three ring occlusion test or a deep ring occlusion test. Now, in our practical video, we will be exactly showing you where are these points. So we need to occlude all the three. First, open the three fingers method is open the or lift the femoral triangle, fem, and see whether you have something comes out from there, the swelling that we have already identified, or it is appearing from the superficial inguinal ring or the deep inguinal ring. And this is known as three fingers, the three ring occlusion test. The other thing that we do is the other thing we do is the deep ring occlusion test. Now, you need to be very careful. The deep ring inclusion test, the ring lies just above 1.25 centimeter, which is half an inch, half the size of your fingertip. It is just this above the middle point of the inguinal ligament or the mid inguinal point, which again you need to be very sure the exact location. Ask the patient to lie down on the couch and do the deep ring occlusion test and the three ring occlusion test. You know this is it is a reducible hernia, and now you know that this is a direct hernia or most probably is an indirect hernia. Rest of the test, you know, maybe some of the examiners would ask you to do, but most of examiners would just give you leverage if you do these two tests correctly and you move forward because there is lots of it. If you now notice that the same person who was standing in the in the start of the examination is now lying down, and you have done the three ring recursion test, and you need to examine the abdomen as well, or you have already done the examination as well, you do the coordinate sign. सर के पीछे दोनों हाथ रख लें and ask the patient to lift up like this, right? And ask them to hold themselves. If they hold themselves there, so you'd see that something comes out. A very important example, very simple example. This patient has a loose abdomen and she complains of a small umbilical hernia. So we just ask her to do a coordinate sign. As she lifts her head up, there is a large hernia, incisional hernia, develops in the same belly. There you go. So this would not appear with a cuff sign, or if it does appear, it is a smaller size. But then if you ask the patient to raise the intra-abdominal pressure by the coordinate sign, by raising both the lower limbs together, both the legs together, or they raise the head under pressure, or you may put your hands on the head and ask them to push. So you would find that the patient has a big incisional hernia. You can see the scar over the abdomen now. Another example, this patient has a scar, as in we label it as incision hernia, and she complains of a small paraumbilical hernia, and this is the patient. When you ask the patient to cuff, it is hardly anything comes out, but if you ask the patient to do a coordinate sign, look at the big divarication that develops. So the whole divarication, whole recti apart, and the whole of the abdominal contents would come into this. So the management would absolutely be different when you're talking about this patient rather than a patient who will just have an incisional hernia after a low midline incision and is coming out just near the umbilicus. This patient requires complex operations, and we need to sit and talk with the patient to tell her about the possible outcomes and the possible options that we have of an open or a laparoscopic surgery. Again, ask the patient to cough. This patient is lying down. You are examining hernia. Ask the patient to cough again to confirm whether what's happening. So this is what happens if you ask the patient to cough. Now you very well understand that the patient must be having a huge defect from where the whole of the abdominal contents are coming out. So this is important that you do a complete examination. Another example. This is the patient with the incision on the flanks, and the patient comes to you with complaints of pain, not with a swelling. But then when you ask the patient to raise the head, so this is what a big hernia comes out. When the intra-abdominal pressure is raised, the whole scar probably has given way, the whole muscle or the fascial sheath have given way, and you can look again. Look at this. So the patient has a huge lumbar hernia, which only appears when you do a Carnot sign. Another patient, ask the patient to cough, nothing happens. So this is the patient with incarcerated hernia because there are no symptoms. But this patient or a similar patient can come to you with complaints of pain in the same swelling or redness over the skin. And now you would be worried that this is an incarcerated hernia, but now it has obstructed and may lead to gangrene of the. So as I mentioned, when you identify that this is a hernia, for example, this is a hernia, you need to again move to the same side. You need to do the site. So you need to give the size, the shape, the surface, and the surrounding structures, other scar marks, other drain sites, any other hernias, and we completely examine the swelling of the hernia as a swelling. So you can see the other lecture we have on swelling and would give you a very good idea. What do you mean? What do you see? The site means the exact location. The size means a specific three-dimensional measurements. And then the shape, the surface is very important. On inspection and palpation would give you lots of information for starting from the urgency to operate on the case to possible coverage that can be given. For example, the slide you saw a couple of slides back, you saw a patient who has the surface is irregular, is only skin. So when you are planning for surgery on this patient, you need to understand that probably closing it by simple suture is not going to work. And the muscle would be so deficient. So you need to do some kind of, again, a specialist. Do not embark on an operation or do not simply say the patient, this is a common hernia and we are going to operate because there needs lots of time. This completes the examination of the hernia. And from here we move on to the third part. So if I recapitulate, or summarize case, so you need to first examine the abdomen. Examination of hernia is part of the examination of the abdomen. If you do the examination of the hernia first, then you need to do the examination, quick abdominal examination in a second as a second part, but it is a constituent part of examination of the abdomen. If you are doing an abdomen, so we already have discussed that there are three parts. We have completed the abdomen proper. You move on to the hernia. So you complete the hernia, whatever you have seen in this lecture. I hope it would be helpful. But you need to complete all these areas. Ask the patient to stand or keep the patient lying on the bed. Examine it completely. You need to do the inspection. You need to do the palpation. And you need to do the auscultation. You need to know whether it reduces, and it's compressible. You need to know whether it is stuck there. Are there any other scars? You need to see any relation in the abdominal cavity. You also need to identify any risk factors. So the examination of abdomen had the first part of the examination of the abdomen or the abdomen proper had five parts: inspection, superficial and deep palpation, palpation for organomegaly, liver span, percussions, and auscultation. And the three parts of the examination of inguinal hernia are inspection, palpation, and auscultation. Examination of swelling would come in, and I have just mentioned in my talk that we are going to have a separate lecture on this, because whenever you have a swelling, you have varicocele or you have a testicular mass and you have a right direct inguinal hernia, so there would be two examinations. There will not be one examination. So there would be two examinations because both the swellings are of different entities and they present differently and the management are different, and you are going to do something different for both of them. So it's very important to do the examination of swelling as many times as there are swellings. In our next lecture, we will be talking about the digital rectal examination, something about the pervaginal examination and the examination of the perineum. So I hope this lecture has helped you. I'll try to put the links on here so that you will be able to link the other lectures that we have made, and you can comment whether you like the lectures or not. Thank you so much.